Okay, so we're going to be starting our chapter on neurological emergencies. So these are the standard competencies for this particular chapter. This is applying the fundamental knowledge to provide basic and selected advanced emergency care and transportation based on the assessment findings for an acutely ill patient. That's pretty standard all the way across, right? That's that sick or not sick that we talk about in class. So this absolutely applies when it comes to altered mentation, which is going to be a fundamental aspect of your neurologic emergencies. So as this slide shows basically what I just said, your anatomy, the presentations, and the management of a decreased LOC or somebody who's unresponsive, the anatomy, physiology, and pathophysiology, and the ways to assess and treat any of these conditions, which would be seizure, stroke, or a TIA, and then a status epilepticus, which is a seizure that is in continuation, and then severe headaches, right? We're not talking about the, oh, I got a little bit of a headache. We're talking about that kind of headache that patients will experience where it's so debilitating that it's causing nausea and vomiting, some kind of visual light hallucination, stuff like that. So again, try not to confuse the two. A small or low-level headache is much different than a life-changing event like a debilitating migraine. So stroke is the 5th leading cause of death in the United States, and seizures can result as a result of a recent or an old head injury, brain tumor, metabolic problems, or genetic disposition. And in reality, most seizures that cannot be pinpointed to a specific cause are called epilepsy. And that just means that there's a unknown reason for why there's some misfiring in the brain tissue. Altered mental status is a common presentation with patients with a wide variety of medical problems. So again, sick or not sick, and then try to remember that acronym AEIOU TIPS, which will lead you down several different pathways for altered mentation. It's something that most providers will tell you we use the algorithm of that particular acronym in almost any case when we're dealing with patients who have altered mentation. Reflexes that protect an awake person may not function when the nervous system is depressed. That's that somebody who's completely unconscious will tend to not withdraw from pain, and there's certain posturing like decerebit and decorticate, and so we'll get a little bit deeper into that later on. In reality, the nervous system, including the brain and the spinal cord and the major neurons, are some of the least understood parts of the human body. It's really complex. It operates under a little bit of a different parameter than most cells, and the structures are completely different, and the way that they utilize electrolytes or create electrical pathways are a little bit different than a normal cell in the way that it functions. And so you have to divide this into two different groups. You've got the central nervous system, which is the brain and the spinal cord, and then we have the sensory nerves and the motor nerves. So if you guys remember affect and effect, sensory being the affect and the motor is the effect. So the central nervous system is ultimately responsible for most, if not all, fundamental functions. The way that the brain and the nerves communicate together help the body create and function normally. You have some automatic processes, and then you have some that you can control. Two of those being heart rate being controlled automatically by demand as determined by the central nervous system. And then the respiratory is autonomic in some regards, but you can actually override it manually, something that we're not able to do with our heart rate. The major structures of the nervous system are divided into those two groups that we just talked about, and that's the central nervous system, which is, again, the brain and the spinal cord, and then we have the peripheral nervous system, which is the afferent and the efferent, or sensory and motor. Now we're going to talk a little bit about the structures of the brain. You guys can see the cerebrum, the skull, the brainstem, the cerebellum, and the spinal cord. And so the hypothalamus and the pons live kind of in that lower part of the brain that runs into the spinal cord. The cerebellum being fine motor control, the cerebrum or the frontal cortex is the logic center, and this can get really, really in depth, and you guys can kind of get off into the weeds on that on your own, but for basic functions, just understand where some of the things are happening. So again, cerebellum controls the muscle in the body. This is more coordination, right? The ability to have coordinated movement to the hand, your ability to balance or perform complex motor tasks are all coming from the cerebellum. There is the cerebrum, which is divided into the right and the left cerebral hemispheres. And so if you guys all look at an anatomical drawing of the brain, you can kind of see that wavy pattern split into two large hemispheres. The front, again, controlling the emotion and the thought or the logic process. The middle controls the touch and movement, and the back processes sight. And that's all, again, in the cerebrum. This is a decent picture of the spinal tract and where all the major nerve roots are coming into. This can also go into referred pain if you really want to get into this, and understanding why people feel pain from some kind of inflammation of an internal organ because of where the nerve root actually passes along it. There are 12 cranial nerves that run directly from the brain to the parts of the head. The rest of the nerves join in at the spinal cord and exit the brain through the foramen magnum, which is that large hole in the base of the skull, which lets the spinal cord connect to the brain tissue. So as you're looking at this is kind of like a chart of dermatomes. This is, if you're looking at the picture pretty closely, you can see C3, C4, C5, C6. These are all areas of major control. And obviously, if you have some kind of interruption in the upper spinal cord, everything below that is going to be affected. But when we're talking about those dermatomes, we're talking about what nerve root is actually functional in regards to where it's being picked up for signals. So one of these things that I would tell you is like something that's a phenomenon for me is positional sleeping, where I'll have my head kind of push forward a little bit or something like that. I will actually lose quite a bit of sensation in a couple of fingers, and I have to adjust my shoulders or my neck. And because of that, it tends to be C7 and C6 seem to have the inflammation process or are being impinged when I sleep in a weird position. So if any of you guys can relate to that, just like being positional and losing sensation or having some kind of aggravating symptom, you can really understand the dermatomes. So what exactly are nerve cells? And that's three basic parts of the cell body: the axon and the dendrites. That's a total neuron. The interaction between two neurons occurs at the synapse, and the synapse is present wherever a nerve cell terminates. Most neurons use neurotransmitters to transmit their signal across the synapse to other neurons. And so that's a chemical messenger that tells the next nerve or next piece of tissue to do what it wants. So while we're looking at this kind of exploded view of a neuron, you can see that there's the major cellular body, right, which has the nucleus, and then you have the axon, which is kind of the long, we'll maybe call it like an arm that branches out into small fingers, and that's the axon terminals with the dendrites on the other side. Those two, as you can kind of see, there's synapses. That's the small gap between the dendrites and the axon terminals, and that's the place that these chemical transmitters are communicating across. In regards to pathophysiology, there's many different disorders that can cause brain dysfunction or other neurologic symptoms. The brain is the most sensitive to changes in oxygen, glucose, and temperature, and by that there is a blood-brain barrier, and there are certain things that are able to get across the vasculature into the brain tissue itself. Again, remember that red blood cells or blood outside of vasculature is actually toxic to most tissue, including brain tissue. Brain tissue is one of the few tissues that is unable to actually regenerate itself, and because of its inability to regenerate, it will actually rewire neurons around damaged paths. But The brain is the only organ that cannot function without glucose. And so for those people that are on the ketogenic diets or what have you, where their bodies are running on ketones, which is a process of fat being converted, the body will it's called glycogenesis. It's a way of converting fats and proteins actually into glucose. So the human body is pretty clever about that, and it can actually convert those materials into glucose specifically to feed the brain. The rest of the body can actually survive without glucose. If you were to never eat carbs again, you would still survive on it, provided that you had a balance between the fat and the proteins, with the vitamins and minerals that are included in that. Temperature is very temperamental in regards to a brain. That's why when we have small children who are really, really highly febrile, we can send them into a seizure as well. Other disorders include the infection and the tumor, and remember, tumors can be benign or cancerous. And a tumor is really just kind of an abnormal growth of cells that tend to replicate themselves, and whether or not they're cancerous or not is something that's determined in the lab. In regards to strokes, right out of the gate, we should probably just differentiate between stroke and a TIA. And a TIA is what we would like to call like a mini stroke. The thing that determines whether or not it's a TIA or a stroke is that TIA, the symptoms will self-resolve, and that's the body is able to push the tiny fragment of clot or the occlusion down deep enough, and it will eventually dissolve itself to where that TIA resolves, because we've restored blood flow to that section of brain that's hypoxic. In a true stroke, you either have the bleeding kind or the occlusion kind, and so very rarely in strokes do we have a hemorrhagic stroke, and there's no telltale way to know that. Like in regards to whether or not you're going to diagnose if something's a hemorrhagic stroke, ischemic stroke, the symptoms are probably going to be the same, because the end result is there is tissue that's actually being kept from being oxygenated and having waste products pulled from it. So here we're talking about a little bit again, right? We've got the thrombus, the arterial rupture, and the cerebral embolism. And this is just kind of a short graph as far as signs and symptoms. And again, we can say this in regards to a heart attack or a stroke. Time is of the essence, because for every minute that those cells are going without oxygen, we're actually creating more damage. So we really want to try to make sure that we get the onset of symptoms as a trigger for how long this event's been taking place, because it's going to help determine what the likely outcome of the patient's care is going to be and whether or not they're going to survive the event. In regards to the ischemic stroke, blood vessels blocked. It could be fat tissue, it could be a clot, something else breaking off of a artery where it now is free floating, and it basically ends up wedging itself into a pipe that's too small to take it. So as that chunk breaks off, whether again it's a clot or a piece of fat tissue or something like that in the vasculature that's broken away, when it wedges in, the branching behind that particular clot is going to affect that large portion of brain, and it is now hypoxic, and basically the brain cannot go anaerobic, right? It has to have glucose and oxygen delivered constantly for it to function. It does not have any kind of reserve. So we all remember some of the basic symptoms, right? And we really like to kind of favor that Cincinnati stroke scale, because it's inclusive of most of the things that are going to happen. And in this slide, you can see that it has loss of movement on an opposite side of the body. There's some confusion or inability to speak. The embolism could block blood flow, and then they could have very few symptoms to complete paralysis. And when we're thinking about that, we're looking for weakness or loss of motor control, and it doesn't have to be the actual whole hemisphere of that body, right? We don't need, like if we're having a stroke on the left side, we don't need the entire right side to actually have paralysis or weakness. It could be an isolated extremity weakness. And so don't get caught in the idea that these things are completely just self-evident when you're kind of communicating with that patient or assessing them. They could be very subtle, and you always want to err on the side of caution. Hemorrhagic strokes are bleeding inside the brain, right? And so again, this is something that you guys can't really diagnose in the field, and it's really hard to kind of deal with, like in regards to trying to figure out what it is that you would or would not do for that patient. In any case, anybody that's experiencing stroke-like symptoms should be transported immediately without a delay by doing extra assessments. So as this says, it's often fatal, and that's because ICP is going to continue to go up. The body is going to respond because it knows that the brain is actually losing its ability to oxygenate, so it sends out signals that it needs blood pressure to increase. And as that blood is leaking from the kind of non-intact vessel, the actual blood starts to crush and kill tissue in the brain. And as that does that, we call that like a hemorrhagic shift, where the blood will actually squeeze and crush all those cells into a compressed state, and that section of brain is no longer there. Therefore, it's really unable to actually do anything. And so once it gets to a point where it actually hits very integral parts of the core parts of the brain, which is where most strokes will start, which is going to be, in the center of the brain, or near the foramen magnum, because that's where the vessels are coming in. Those key fundamental parts that control life are going to be destroyed, and it ends up actually causing death. This is just talking about the ICP that I had mentioned, right? So that's putting that blood into the actual, finite size of the cranial vault, and as again, the rest of the brain is screaming for oxygen because it's now being choked off with the blood not being allowed to get to where it needs to be. The body is going to increase that pressure, and then the herniation or the shift will actually happen. It's a pretty good diagram of how this is actually working. You can see somebody's bleeding from the right side of the, or I should say from the patient's left side, and you can see as it's crushing in, it's third spacing all of that, and that tissue is being destroyed. This is the TIA, and this is, again, the body is resolving the clot on its own, and those symptoms will go away. In this slide, you can see it actually says that it's a warning sign that a larger stroke is imminent, and that's very often true. Quite often, people will have a large event and then will continue to have TIAs later on in life, and that's just because they're already at super high risk to have another large event. Now, if we're looking at the signs and symptoms, this is really where it kind of boils back down to that Cincinnati stroke scale. We've got the facial drooping, the sudden weakness or numbness in one side of the body, a decrease or absence of movement and sensation on that side of the body, the inability to walk because they don't have motor control to the leg or their balance, and then sudden vision loss. One of the few things that we don't talk about very often is a lot of times when you're asking somebody to look, if they're having a little bit of a larger stroke, they tend to look to the side that the stroke is happening on. So if you have somebody that's kind of looking purposely up and to the left or just completely to the left, that usually means that they're having a left-sided event, and you're going to find the weakness or the inability to have motor control on the right side of the body. Some of the other symptoms are dysphagia, the decrease in level of responsiveness, aphasia, slurred speech, sudden and severe headache, confusion, dizziness, and then comatose at the end. These are some of the ways to kind of help determine that left or right hemisphere problems, right? We've got the left hemisphere may cause the aphasia, the paralysis of the right side of the body. The right hemisphere can cause paralysis of the left side of the body. Words can be slurred or hard to understand. And then bleeding in the brain. Again, you're not going to be able to tell that in the field clinically. So there are a few conditions that may mimic stroke, and that's hypoglycemia, a postictal state, or a subdural or epidermal bleeding. And the epidural bleeding or subdural bleeding is putting pressure on the brain, right? And that's most often dealt with in the hospitals by creating some kind of a shunt. They'll vent the cranial cavity to allow blood to kind of evacuate itself due to pressure. In the postictal state, people are often obtunded, their pupils are going to be dilated, and they're not going to be responsive. So again, falling down that AEIOU tips is going to help us determine kind of where we're at. And just remember that we never stop with the first one that we find that has a positive. We want to make sure we go through the entire algorithm, right? We may have a alcoholic who is obtunded, who also has diabetes, who also has seizures, right? All of these conditions can actually kind of co-found one another. And at the end, I mean, you could have the perfect storm of symptoms and events that are causing that altered mentation. This is just letting you know that the subdural bleeding is usually as a result of a trauma, and this could be a minor trauma, right? And this is why we're very concerned with people who are chronic alcoholics who have lots of falls, because they may have just barely hit their head against the ground, and it was enough to create that rupture in the vasculature or the venous side, and they could just start kind of packing blood into that subdural or the epidural lining, and that's creating that shift in the skull for the brain tissue. Remember, the skull cavity is a finite space. The brain takes up the overwhelming majority of that with just a little bit of room for CSF. And so anything else that's leaking into that cavity really has no room, and the soft tissue is going to be pushed out of the foramen magnum. Seizures, this is just describing what a seizure looks like, and if you haven't seen one, it's sudden and erratic jerking, spasming, and kind of clenching and going flaccid, right? This is erratic firings of the neurons, and really this is just the synapses are firing in non-communicative order, and I could liken this much like VFib in a heart, where the cells and tissues are all firing independent of one another and they're not timed and synchronous anymore. The same thing can happen in the brain, where we start getting just mismapped and random firing of electrical signals throughout the brain that cause the body to basically shut off, and then we get the erratic kind of contractions of the motor system. So it can be something where it's complete, right? And that's the full tonic-clonic seizure, or you can literally have a single extremity that is having that. And or it can be just a single extremity that is experiencing the erratic movement or loss of sensation at the same time. That's a focal seizure. And a lot of patients will tell you that they get what they call an aura, which is a metallic taste in the mouth, a certain sound, or a certain visual disturbance before they actually go into the seizure. So again, generalized tonic-clonic, they used to call that grand mal. The absence of that is a petit mal, and then pseudo-seizures. And pseudo-seizures is really just a nice way of a patient, a nice way of saying that a patient is self-inducing seizure-like activity, or we could just ultimately call it kind of like a fake seizure. This is usually a psychiatric issue where that patient has a behavioral issue. So then we have partial, which is you can have a trunk or a core kind of seizure-like activity, and then you have complex partial, and I'll let you guys kind of dig into that. It's in the book, and you can get a lot deeper into it, but this is something that you just kind of start to recognize when you see several of them in the field, and sometimes we can get fooled by the people with pseudo seizures. So make sure that you're being a good student and actually looking at that AEIOU tips, and go through the algorithm, like really understand what's happening, and make sure that you're doing supportive care. Unfortunately, at your level, you're unable to give the medications that are necessary to assist in the stop of a seizure. So anything that you are going to do is going to be supportive care. Okay, so in this table, 19.3, this is the common causes of seizures. And you can see the one in red there where it says idiopathic. that's of no known cause. And that's usually when we start to actually say that people have epilepsy, and that's because we just don't know why they have it. We don't have a way to actually treat it. So that those people who continually have these seizure kind of episodes will be put on a couple of different medications to help stop that.